I see a lot of people here wearing glasses, okay? Actually, a couple of years ago, I was wearing glasses too, but you guys know when you're wearing glasses, when it's wintertime, and you're coming from the outside inside, it's like hell for 10 minutes. You don't see anything anymore. For sports, it's not easy. For a couple of things, it's complicated. When you lose your glass, you're like blind. When somebody hits you in the face or punches you, you can actually lose an eye. So the next guest is a personal friend and actually someone who did the eye surgery on me. He's also a big fan of heavy metal music. Ladies and gentlemen, please welcome Vincent Kin.
Ladies and gentlemen, dear colleagues, dear friends, it's really good to be here in front of you today because we're going to talk about something that is going to probably surprise you or at least titillate your interest. We are going to talk about sight, how to improve your sight or how to improve the sight of your patients. So we're going to go over eye operations in 2022. Where are we in the field of eye surgery? We're first going to talk a little bit about laser vision correction with laser surgery, and then we're going to go over the most common surgery in the world, cataract surgery. We're going to go over the stages, we're going to show you some videos about how it happened, and also we're going to talk about the implants that we put inside the eye of patients after the surgery. So please tell me, in front here of this audience, who has done or who is planning to do laser vision correction? Now, that's still quite a lot of people. I mean, you guys are pretty much a lot myopic because you did quite a lot of studies, so that indeed would increase the amount of myopia that people have. As a matter of fact, laser vision correction is just one set of a part of surgical techniques that allow you to not wear glasses anymore. So we're going to talk about laser eye surgery to correct myopia, hyperopia, astigmatism, and presbyopia. We're going to talk also about some other techniques which allow you to not wear glasses anymore apart from laser. We're going to talk about phakic intraocular lenses. That's for basically people who have a lot of myopia, -10, -12 diopters of myopia. Or we're going to talk to you about refractive lens exchange, which is exchanging your lens with an intraocular implant, even though you don't have cataract surgery. So myopia, hyperopia, what is it? What is it actually? So as you know, hyperopia is the fact that your eye is too short in your anterior to posterior length. And since the eye is too short, ray lights coming into your eye are actually focusing too much behind the retina. And so it's all blurred. Myopia is the inverse. You have an eye which is too long in their anterior-posterior segment, and so ray lights focusing in the eye are too convergent, and they're actually focusing too much in front of the retina, which means that you see all blurred as well. In addition to that, you also have what's called astigmatism. And astigmatism is the fact that the cornea is too steep in one direction more than the other, which then provides a defocus in all directions and distances, but across different axes. And so basically, a lot of people have myopia, or even astigmatism or hyperopia, they don't even know about it. So what's the purpose of laser surgery? Well, it's to change the curvature of the cornea, which is the anterior glass of the eye, and by changing the curvature of the cornea, it will make the cornea either steeper in myopia or flatter in the case of hyperopia, and it will allow you then to not wear glasses anymore. Okay, so the principle is to modify the shape of the cornea so that the image of an object is formed back on the retina again, okay? So in myopia, you would want the ray lights to converge back on the retina by flattening the cornea, and in hyperopia, the inverse. So what usually is being used when you have laser vision correction is two techniques, PRK, surface laser ablation, or LASIK. PRK is probably the most standard technique. It will actually resurface the cornea by doing a surface laser ablation without a flap, so purely on the surface of the eye. What's the indications? Myopia between minus 0.75 diopters to minus 6 diopters, and it can correct astigmatism up to 4 diopters. If you have some disease, if you're pregnant, if you have previous ocular disease, if you have keratoconus, immune disease, then don't go for it, because these are contraindications. Now, sometimes after PRK, you have about 2 to 3 days of pain and recovery period, with a recovery of vision taking about 5 days after surgery. And final results are happening between 1 and 3 months after surgery. Very rare complications, usually infections, like with any type of surgery, you can have infections, so 1 case out of 10,000 statistically, and you also could have haze, which is the equivalent of having an overscarring of your cornea, and that could provide you with a veil on the cornea, and that is happening in less than 100 cases. So in PRK, it's basically 10-minute surgery. You have a local drop, which is providing local anesthesia, and then you do some preparation work, and then the laser will actually polish the surface of the cornea for about 10 seconds. And then it's over. It puts you with the contact lens back on again on the surface of the cornea, and the surgery is done. And you leave with that contact lens for about 5 days. Now, I'm going to here show you a little video about practically what is happening with a PRK surgery. All right, so here you have a patient. He's about minus 3.75 with a little bit of astigmatism. Very standard procedure, very standard case with standard indications of PRK surface laser ablation. And what happens is that you have local anesthesia drops, so the patient doesn't feel anything. He looks straight into the laser, which is actually just a light, and he doesn't see the laser. Then we do some preparation work with a little bit of alcohol in a well that you drop onto the surface of the cornea, so that the epithelium, which is the first layer of the cornea, can be removed more easily. Okay, so now the alcohol is applied, and what you're going to do is you're going to scrape off the epithelium. So that's the first layer of the cornea. The first layer of the cornea, you have to remove it because otherwise the laser doesn't work. And once it's denuded, and once the surface of the cornea is apart from the epithelium, then you don't have any epithelium anymore. You irrigate a little bit, and then you dry. It's very important to dry the cornea before applying the laser. And then the patient is completely awake. He really doesn't feel anything. He just looks at this green light all the time. And then, you get calibration, and then the laser will work for about 8 to 10 seconds. And you'll see that the laser spots are actually very small purple spots. Here it goes for a few seconds, and it's finished. The laser is finished in about 8 seconds, and it really scans the whole surface of the cornea by polishing it and making a curvature that you want. And then at the end, you usually have to apply some additional mitomycin, which is a special product, which allows you to avoid having haze, which is this overscarring of the cornea, which could lead to suboptimal results. And then you irrigate, and then you put a contact lens on, and it's over. Second option, LASIK. LASIK is also very common, and it's pretty much a variant of the PRK. It corrects from minus 1 to minus 8 diopters of myopia and astigmatism of up to 4 diopters. It can also correct hypermetropia for up to plus 4 diopters. Now, not all people can have LASIK, because you have to have a certain degree of corneal thickness, which is about more than 500 microns of corneal thickness, to be able to do LASIK. Now, the advantages of LASIK is that basically it's painless and you don't feel anything even after surgery, with an immediate effect of vision recovered after just 24 hours. PRK is about 5 days. Now, some LASIK could have complications, although it's very rare. Less than 1% of cases could have some inflammation in the interface of the flap, because you see that there is a flap, or in rare cases, ectasia, which is basically a steepening of the cornea a few years after surgery, which is not wanted. So in LASIK eye surgery, which is about 40% of cases and 60% of cases being PRK, we have also local anesthesia, and then we create a flap in the thickness of the cornea itself. 100 microns deep for the 500 microns of thickness of cornea, and then you create this flap with the first laser, which we call a femtosecond laser. Then you do a second laser, which is the correcting laser, sculpting the surface of the cornea, and then you position the flap back on again. So basically, the first laser is a femtosecond laser. It creates a flap, okay, but there's still a hinge connected to it. And then you do the second laser, which is the correcting laser, on the residual cornea, and then you clip the flap back on again. And so here in images, how does it happen? First laser, femtosecond laser, you dot the eye with this first laser, which creates a flap, and it really creates an interface with very, very small millions of bubbles connecting with each other. So there's an interface which is then created at 100 microns deep of the cornea. And then when the flap is created, you need to lift the flap. So you need to lift the flap with small instruments. You first delimit the interface of the flap in the periphery, the hinge being here, and then you go with a small spatula inside the interface and you try to lift it. And here it goes, your flap, very well done on the periphery. And now that the residual stroma is denuded, it's ready for the laser. And the second laser does the correction by polishing the residual stroma, and it will then have these purple spots, as you saw with PRK, same laser, does the correction a few seconds, 8 to 10 seconds, and then once it's done, you clap the flap back on again. And so here you go. You have this correction actually done in about 10 minutes in total. So here's the flap being repositioned, and then some additional irrigation under the flap so that there is no debris being left over, and then you have your surgery being completed. So PRK surface laser, 5 days recovery. LASIK is more about 1 day recovery, so very quicker, and also not a lot of pain after surgery, but a little bit more invasive on the conceptual side, although both actually have pretty much the same results if you are between 0 and -6 diopters. So in practice, well, it's about 15 minutes per eye, so 30 minutes for both eyes together, local anesthesia, no hospitalization. The price is usually about between $2,000 and $350, and there is a very small reimbursement from the health insurance. Sometimes people can have some dry eye after surgery, and that usually goes away after 3 to 6 months. Sometimes you can have some optical aberrations, which is halos around lights at nighttime, and in 10 to 20% of cases, you can, after 10 years, have a small regression, which is myopia coming back again. But if you have regression, and you are in 10 to 20% of cases, it's usually a partial regression. So if you have -5 and you are put back to 0 after surgery, then if you have regression, it's about -1. It can never go back to -5. That is not possible. And so that's kind of equipment that is usually used, and what is usually used also nowadays are what's called next generation lasers, which make the possibility of tailor-made treatment possible with additional customized treatments which can recognize your iris so that even when you move your eye during the 10 seconds of laser, well, it's not a big deal. The laser moves with you. That's called iris recognition and tracking, and that usually now is integrated in quite a lot of lasers. Now, apart from laser, I mean, some people, they can't have surgery because they have -10, -20 diopters of myopia. And what happens then is that we can give them phakic intraocular lenses. It's like a contact lens, basically, but it's being added inside the eye, but forever. And you don't need to take it out. And this intraocular lens is called usually an ICL lens, and it's positioned in front of the natural lens. So that's the crystalline lens. In front of the crystalline lens, behind the iris, this ICL stays and corrects for the whole range of myopia. And a last thing that you can do if you want to correct your vision, and if you're older, it's not for young people, it's for 50-plussers, it's basically a cataract surgery in people who don't have cataract, which means it will exchange your lens. Your crystalline lens can be aspirated and replaced by an intraocular lens, an implant, which can be a multifocal lens, we'll see that later, which allows you to have a good vision for far and for near. So this is basically a cataract surgery, but without cataract, without a lens opacification. A last technique is radial keratotomy. This is completely obsolete. It was being done in the years 90, and nowadays it's considered obsolete because it doesn't give good results, but probably, you know, your parents had it, or you have some older cousins who had it, and there's quite a lot of people who had this. You had incisions, radial incisions that are being made on the cornea to correct myopia. That this unfortunately doesn't work, and we see that this causes a lot of complications actually. So that was for vision correction. Now we're going to go over cataract surgery. Cataract surgery, who has actually in their internships here assisted in a cataract surgery or seen one? Well, there's quite still a lot of people. Actually, cataract surgery is the most common surgery in the world. All surgeries in medicine combined. It's more frequent than appendicitis. It's more frequent than teeth extraction. It's actually almost physiological to have a cataract when you grow old. So this is usually a disease of older people, although not necessarily always. What is cataract? It's basically an opacification of your natural crystalline lens. This crystalline lens, with age, becomes opacified and you don't see anymore. So you have a clouding of the lens, mainly due to age, and it does cause a decrease of vision for a distance, sensation of veil, sensation of glare, and hypersensitivity to light. Oh, you have this patient who has actually very, very much hardness and difficulty to drive at nighttime because he's so much sensitive to light at nighttime, and he wasn't there like that a few years ago. That's a cataract. Decreased contrasts, blurred vision. It's basically causing a lot of symptoms which are causing bad vision. Sensation of veil, glare, decreased in contrast, and blurred and darker vision. That's usually what happens in cataract. Usually it's due to age, but sometimes it can be earlier in some people who have specific diseases like diabetes, myotonic dystrophy, atopic dermatitis. Traumatic cataracts can happen. When you take a lot of cortisone, a lot of Medrol, it can give you a cataract even if you're 30. Some ocular diseases, pre-existing ocular diseases and conditions can also lead to a cataract, like, for example, chronic uveitis, ankylochoric glaucoma, retinitis pigmentosa. Any kind of chronic ocular pathology can actually give you cataract. And lastly, congenital cataracts, that is cataract in babies. Well, that happens when you have metabolic disorders like galactosemia, metabolic in utero infections, etc., etc. So quite a lot of possibilities, although they quite, look pretty much the same because most cataracts are what we call nuclear sclerosis. It's basically the lens which is being opacified in a whitish or yellowish or greenish matter. So if you see this dilated anterior segment photograph, you see that the lens is actually not transparent. It is not completely dark because it's supposed to be dark in the pupil. It's actually bluish or yellowish or green. Now, nuclear sclerosis, you can see it very well, the slit lamp. It is usually very recognizable, and as long as the lens is not completely transparent, then you have a certain degree of cataract. You can also have what's called a cortical cataract, which is quite frequent as well. It's the second largest type of cataract nowadays, and that's basically you see all these radial opacities happening from the center to the periphery. Well, these are called riders, and these riders are becoming opacified and give you this typical shape of cortical cataract. And the third and last type of cataract is called a subcapsular cataract. The subcapsular cataract is right under the capsule of the posterior segment. So you have the posterior capsule, and you actually see this yellowish matter being really adherent to that posterior capsule. That's called a posterior capsular cataract, and that is especially associated with the use of cortisone. So cortisone-mediated cataract usually happens this way. It doesn't really matter what type of cataract you have. Actually, the treatment is the same. You need surgery. You need surgery, and you actually need to extract this cataract and replace it with an artificial lens. So this is a very common surgery, but we don't necessarily operate every cataract. Actually, it needs to be problematic for the patient. It needs to give them a decreased vision, which is not always the case. If you have a patient who has 10/10 vision, you don't need to do cataract surgery. But basically, when vision is being decreased to less than 7/10 or 7 out of 10, then you need to operate it. Or when the patient is very, very much problematic with photophobia or with visual discomforts, or when you want to do a refractive lens exchange because the patient doesn't want to wear glasses anymore, then you can do cataract surgery. Otherwise, it's not really necessary to do it. So how does it happen? I mean, this most common surgery in the world actually happens usually under local anesthesia. It takes about between 8 minutes and 20 minutes. You don't necessarily need to be hospitalized. It's purely with a local anesthesia with drops, and the patient is lying down, and then we do the disinfections, and then the patient doesn't have to move. It's very important he doesn't move, because otherwise it can lead to complications. So we first do some incisions, a 2.2 millimeter incision, actually really on the cornea itself, but on the periphery of the cornea, which is called the limbus. The limbus is the distinction between the line demarcating the cornea and the sclera. And then you do this 2.2 millimeter incision, which then allows you to have an opening, and then after this incision, then you inject some additional local anesthesia, which is usually linezol, in what's called the anterior chamber. So the anterior chamber is this space between cornea and the iris. And here you also then need to inject viscoelastic material. It's this viscous material, being transparent, which is very indispensable. You inject it because it creates space. Otherwise, it collapses and you don't have space to work. So you need to create a space so that you have enough space to maneuver for the rest of your surgery. Once this viscoelastic material is injected and you have enough space, then you need to open the anterior capsule of the crystalline lens. So you have to do what's called a capsulorhexis, which is basically a circular opening in the anterior capsule. And then you need to extract this cataract, so you first need to crack it in several pieces. That's called phacoemulsification, phaco being crystalline lens, and emulsification being to eat it away. So you create some grooves, and then you try to crack it into 4 quadrants, and once you have the quadrants, then you aspirate them. It's called divide and conquer. Divide and conquer, you basically divide the nucleus into a few lens pieces, and then you aspirate them. And then you need also to aspirate the cortical masses in the periphery, and then in the final stage of it, okay, you're clear, there's no cataract anymore. Now you need to replace the lens with an intraocular lens, an artificial lens, an implant, and this implant is calculated so that you don't need glasses anymore for far. This implant is actually injected through the 2.2 millimeter incision directly into the capsular bag, and then it unfolds itself completely and automatically, and it stays like this for the rest of the life of the patient. No need to take it away. So at the end, you actually have to aspirate the viscous, you clean everything up, and then you don't need a suture of your incision. You just hydrate the suture, and it becomes a little bit swollen, and you don't need a suture because it collapses completely the incision. So usually you don't need any kind of suture. Now, this in practice means that it would take you about 8 to 20 minutes. First, you have the incision. Okay, it's not painful. The patient is completely awake as well. No problem. He's not feeling anything. You inject then this viscoelastic material so that you have enough space in the anterior chamber. Once you have enough space in the anterior chamber, you do the main incision, 2.2 or 2.4 millimeter incision. It's called a clear corneal incision on the limbus. Once it's done, then you open the anterior capsule with this famous capsulorhexis. It's a very delicate maneuver there. You don't want a patient to move, because if the patient moves, then basically your capsulorhexis is not continuous or circular. Once it's open, you need to hydrodissect, which means you need to inject some water in the capsule, under the capsule, so that there's water around the whole nucleus of the lens. And then you can try to move it around so that it's separated from the capsule. Then you do the grooves. You do this phacoemulsification, whereby you actually crack in several pieces the nucleus of the crystalline lens. Once it's cracked in 2 pieces, you turn it around and you crack it in 4 quadrants. When it's being done, you actually aspirate them. You aspirate them with this phaco machine piece in your probe, in your hand. It's being done manually. There's no laser actually which can do this, so it's not being automated. And once it's done, then there's no nucleus, but just some peripheral cortex remaining. And the cortex you aspirate it with another smaller probe, which is called the cortical aspiration. Once the cortical aspiration is finished, then you have your capsular bag completely free of cataract. Then you inject some visco, create some space, and then you're ready to do the implantation. The implantation means just injecting this intraocular lens completely in the capsular bag. So here, there's this visco being added. There's the lens being implanted. It's actually being loaded in an injector so that it folds itself, because otherwise it's too big to enter the incision. Then it's actually injected inside, and then it unfolds itself by itself automatically. Once it's unfolded, it's in the capsular bag, and it's perfectly centered. Then you aspirate the visco, because you can't leave it like that, and then you hydrate the incisions. So you basically close up the incisions so that it's a sutureless surgery. Okay, now the evolution, usually after a few days, the patient will increase their vision so that if pre-op the patient has a visual acuity, a corrected visual acuity of less than 7/10, after surgery you can expect it to increase to 8, 9, or even 10/10 at 1 week. Usually the lens is calculated so that you don't need glasses anymore for far, but for near usually you need lenses. With at least a monofocal intraocular lens, you need lenses for near. And we never usually operate both eyes at the same time. We usually leave about 1 to 2 weeks between the both eyes. Now there's lots of things that can go wrong with a cataract surgery. Even though it's a very routine and frequent and common surgery, actually there's still complications like any type of surgery. You have no 0% risk in any kind of surgery. So what can go wrong with the cataract surgery? Well, it can go wrong with a posterior capsular rupture. That's the nightmare of every surgeon. What is happening in a posterior capsular rupture is that you have this capsular bag, and then the posterior capsule can become ruptured. If you have a hole in the posterior capsule when you are doing the surgery, then that's a catastrophe, and you can stop surgery immediately because there's pieces of nucleus going through into the back of the eye, into the vitreous, and then you can't finish the surgery anymore. So what happens is that you need then in a second surgery to clean up the rest of the cataracts that have fallen through the capsular rupture and finish it in a second stage of surgery. But you can't continue. So that's basically what all surgeons fear about. Otherwise, you can have a few other complications which are not so problematic. Like that's a posterior capsule rupture, by the way. So you see that there's actually this opening, which is the anterior capsule. That's normal. That's the rhexis. But then you have the posterior capsule, which is completely broken as well, and then you have to stop surgery. You can't just continue on like that. Here you have this posterior capsule being ruptured, so that's a violation, and you can't continue because pieces fall through it. That's actually with a big posterior capsular rupture, then you have a big hole, then the whole nucleus actually drops into the posterior part of the eye. That's called a dropped nucleus. That's like the biggest failure you can have in that kind of cataract surgery. You have the whole nucleus being dropped in the fundus of the eye, in this posterior segment of the eye, and that's the catastrophe. You can have some very, very, very unbeautiful things like this happening as well, when the iris goes through the incision. That's called an iris hernia. That makes surgery very difficult because you have to then reduce the hernia inside so that you can continue on, because obviously you can't live on with an iris hernia like this. And then also, when people have surgery, well, they could have this kind of thing happening. That's very rare. And does anyone know what this is? What's an endophthalmitis? It's actually an infection of the eye 2 to 5 days after surgery. It's the most severe complication you can have after a cataract surgery. And since cataract surgery is so common, well, this does happen. It's about 1 case out of 2,000, and it's an infection of the eye. You see a level of pus completely being rotten in the anterior segment, and that's very poor prognosis. The eye can be lost because of that, and it could never recover. It's possible. You need to do antibiotics, but it does not really recover that quickly. You have postoperative intraocular pressure, which sometimes can increase, then that could lead to glaucoma, but usually when you reduce it with drops, it's fine, so that's not a very big problem. Sometimes in 1%, less than 1% of cases, you can have retinal detachment, and with a retinal detachment, the whole retina detaches, and so then this needs some additional surgery, because otherwise you can become blind because of that. And you can, after 6 weeks, also have what's called a macular edema. So this is the retina, and the retina can become swollen. When it's swollen, then you have a decreased vision, and it is not good. Your prognosis is not so great anymore. So you need to treat it with cortisone after that. Okay, now, in a lot of cases, you could also have what's called a posterior capsular opacification. The lens, the intraocular lens you have put, is actually something that is transparent, but it could become opacified after a few years because of migration of small cells, which can make it a little bit dirty. That's called the posterior capsular opacification or secondary cataract. And that's not a big deal. You do a small laser, which goes a YAG laser, and you open up the capsule, you wash it up, and that's not a problem. The patient can see well again. But it does indeed provide with a decrease in vision if you don't treat it with a YAG capsulotomy like that one. Okay, and then sometimes you can have very weird things happening, like the implant dislocating and being completely out of place. You can have the cornea sometimes, which becomes a little bit pathological, but that's very rare. It gives decreased vision because the cornea can be very, very fragile. Now, the last thing that I'm going really to focus on, and I'll finish by this, is intraocular lenses, because that is huge. Intraocular lenses were invented in the years 40. Before the years 40, people did not have any lens implanted. So if they had cataract surgery, they had no lenses. And when you don't have a lens, well, usually you have about a hypermetropia of +20, and you don't see anything. But then these lenses were invented because you have this pilot from the Royal Air Force in Britain that actually was having patients who were pilots. And these pilots had big traumas with shards of glass of their cockpit actually in their eye, accidentally. And he remarked that these pilots could see well with a bit of glass in the eye. And so he discovered that actually these natural lenses can be replaced by these intraocular lenses. And nowadays, these intraocular lenses are very important because in any type of cataract surgery, you need to put these lenses inside the eye. So you have monofocal lenses, which allow you to see well for distance, but you also have toric lenses, which allow you to correct for astigmatism in addition to your myopia or hypermetropia. And NEC plus ultra is what's called the multifocal lenses, which allow you to see well for far and for near. So intraocular lenses, basically, it's a small piece of plastic, transparent, and they basically provide for a good vision for far. They're made of acrylic, which is a special kind of material, which is completely inert, so you never have any kind of rejection after that surgery. And usually the shape is with a central optic, and then you have additional haptics. They're called haptics. They're basically paws that allow your lens to be stabilized inside the capsular bag. Now, once you have this, you also have other types of lenses, like plate haptic loops, which are basically not having these C-shaped haptics, but which are having some other types. It's all completely equivalent, and they come with an injector, and so you basically inject it through the incision. You need to calculate the diopter of the implant with that kind of device, and that measures the eye and allows you to suppress, at the same time, myopia, hypermetropia, or astigmatism. It's usually very accurate, and usually after surgery, after cataract surgery, these old people, they have 0 diopters in both eyes, or they could, but they need to wear glasses for near, okay? So presbyopia is not corrected. Presbyopia is not corrected in normal lenses, in monofocal lenses, but it is corrected with multifocal lenses. Multifocal lenses are actually this new generation of implants which allow you to correct for presbyopia at the same time as myopia or hypermetropia for far. And so these people don't need glasses anymore at all. These lenses are very special. You see all these grooves that are being grooved inside the fabrication of the lens. These are very typical for multifocal multifocals. And when you put on these multifocals, then it creates 2 or 3 foci of vision for far, for near, and also for intermediate, so that you don't have a need for glasses anymore. And these lenses, unfortunately, are not reimbursed by the health insurance, but they are very effective. And so you see all these small grooves. Well, the presence of these grooves allow you to have 3 focuses of vision. These are about 10% of people who are having cataract are having these types of lenses, because sometimes they can have some problems. These multifocal intraocular lenses, it all happens well, you have a very clear vision at all distances, but sometimes they can give halos at nighttime. When you drive, it could be very, very annoying. Sometimes in 20% of cases, it can give you some starburst, which is around ray lights. They are actually being very aggressive to your vision because there's too much light, or you can have glare. That is really a pure hypersensitivity to light. So these people, they sometimes have this, so you don't need to put a multifocal IOL in every person because it could give these secondary effects. And so when glare is serious, then obviously your quality of life can be reduced. So you really have to be very careful if you want a multifocal intraocular lens. You need to be aware that sometimes people have these vision complications. And then the last generation is called extended depth of field implants, which allow you to have a good vision for far and for intermediate, but not for near. Now, the advantage over monofocals is, well, you don't need reading glasses. The disadvantage is, the advantage also is that basically you don't have these glare problems. So you didn't have these halos and you don't have these hypersensitivities to light. And if the posterior capsule is actually ruptured, then you have a last type of lens, which is called a sulcus lens. So the take-home message is, and I'll conclude with that, is that basically eye surgery has evolved so much in the last 50 years that ophthalmology is completely unrecognizable nowadays in 2020 compared to the 1970s. You now have laser vision correction, which allows younger people to have a complete correction of their myopia, astigmatism, or hypermetropia with either surface laser ablation or LASIK. Then you have cataract surgery, on the other hand, the most common surgery in the world, which allow you to extract your cataracts or to have a natural lens replacement, and then you replace it with this implant, which can be either monofocal or toric, which corrects astigmatism, or multifocal, or with an extended depth of field lens. Now, refractive lens exchange is basically cataract surgery, but you just extract the clear lens, there's no cataract, and you replace it with an implant. And finally, for very myopic people, -10 or more, lens addition with phakic intraocular lenses, which is a lens added between the iris and the natural crystalline lens for high myopes. And with that, I thank you so much for your attention and am ready to answer any of your questions. Thank you very much.
And so, again, I'm the one, oops.
Ooh.
Vincent is the one doing my eye surgery, so, ha ha ha, that was a joke. So, ladies and gentlemen, do you have some questions for Vincent about the eye surgery? Thank you for the masterclass. And you broke the record today because you had like 100 slides. And it didn't look that way. So, yeah, record holder. So, ladies and gentlemen, raise your hand and stand up, please, if you have any kind of questions. Okay, already. That's good. Okay.
Hello? Yeah. The normal lens has the ability to change shape with the help of the suspensory ligaments. So, the new lens you implant can do the same? No.
So if you implant a normal monofocal lens, okay, it cannot change shape at all, and it only has one focus of vision. And usually it's put for far, and so you have a good vision for far, but for near, presbyopia is not corrected, and you need reading glasses, like old people do. Okay, but if you now put a multifocal lens, actually it does not work by changing its shape, Lenses cannot change their shape because they're completely artificial, so they can't be combined with the ciliary muscles. But the multifocal lenses actually have this technology of concentric rings, which allow to split ray light coming into your eye into 3 foci of vision. One for far, one for intermediate, and one for near. So actually you have a good vision for all distances, but a little bit less light for all distances as well, because the ray light is split in 3 different focuses. But it does not change shape with your eye, like the natural crystalline lens. No, absolutely not.
Hello. I have one additional question. What when you try to remove the nucleus, you put too much traction and you damage the ligament that's attached to the nucleus? What do you do then?
Absolutely. So this is called the zonulolysis. It actually happens in 1% of cases. It's sometimes not a big deal. You have these suspensory ligaments suspending your capsule and your lens to the ciliary muscles. But if these are damaged, then you have this zonulolysis whereby then the lens is not attached anymore and the capsular bag is not attached. If it's less than 1/4 of a clock hour, it's not a big deal. It won't give you anything. If it's more than half of the circumference of the lens, then you need to put in a special device, which is called a capsular tension ring. It's like a plastic ring, which allows the zonulolysis to be completely back in shape. And this is like an elastic material which allows to stretch your zonules and to stretch your capsule so that it's back in the good place again. And then you can continue surgery.
Okay, thank you.
So when you choose the IOL, do you take the tension system into account as well, or doesn't it matter?
You mean the tension system for zonulolysis?
Yeah.
Oh no, the tension system is a completely standard product. It's like the same product for everyone. If there is a zonulolysis, which is quite rare, but it does happen, then you just inject this, but there's no specific measurement for that tension system. It's just one standard product for every zonulolysis.
No, but I mean like the C-loops and the other types of tensions systems, does it matter which type you use? Or?
No, it doesn't really matter. The shape of the lens, the shape of the implant, usually does not really matter that much. Okay. No, it's just every producer, every provider has its own shape, and it does not really give any difference in general.
How do you make the eye of the patient fixed for the operation so it doesn't move while you're operating?
How do you make the patient immobile so that that they don't move their eye? Well, you tell them.
Oh.
You tell them to fix the light. They're really actually under the microscope, lying down, and their head is usually fixed with a sterile draping on it. You have an eyelid speculum for any type of eye surgery, like in A Clockwork Orange, whereby the eye is open, so they can't close their eye, but they don't feel it, and they just need to look at one fixation point, the light. And usually, they obey, which is okay. Sometimes, naughty patients, they move all the time, so then you have to yell at them.
Okay.
And on the last resort, you hit them. No.
Sorry?
Last resort, you hit them.
Last resort, yes, yeah, actually, or you give them some additional anesthesia so that they sleep.
But I mean, truth to be told, I went through eye surgery with Vincent, and the fact that he explains everything beforehand gives you the assurance that everything's going to go fine. Indeed, having the device making you not blink is also something that reassures you, and indeed, focusing, it's like being on a starship. It's like you just have one point where you have to focus all the time, and then it went okay. But mainly, I would say one thing that prevents the stress is also how calm the doctor is, and he was, as you can see, he's somebody who's really composed. Any other questions? So, Vincent, for the moment, we've been talking about putting the eye back at 100%. Do you foresee any kind of future where we would enhance the vision, or is it already the present?
Now, that's a very good question, actually. There are now contact lenses being invented that are being used to enhance your vision so that you have a more than normal vision. These contact lenses have an electronic sensor in it, and when you blink twice, for example, then they can zoom where you fix on. And that is very impressive because that can really give you a zoomed image of a specific place, and then you blink twice again or 3 times, and then it goes back to the normal level. So that now is currently being developed in conjunction with Google. But yes, it does exist. It does exist.
Okay, so guys, Black Mirror already right now. Pretty good. Any other last questions before little break?
Yes.
There, on the right side.
So you talked about the multifocal lenses. Is it possible to implant maybe in the future a lens which autofocus and have a really sharp image even if with infinite focal points? With a motor in it maybe, or something like a retractile system?
Actually, the infinite focal point that you're talking about, this is the point of every lens. Every lens has actually an infinite focal point. When you look for distance, actually, theoretically, you are focusing for infinite distance. So all these monofocal lenses, toric lenses, and even multifocal lenses, they are focused for infinite focus and for distance. And with multifocals, in addition, you have an extra focus for intermediate and for near. They are actually very sharp. So you have actually a very sharp image when you have these multifocal lenses. Now, the only problem is that, as I said, sometimes you can have halos and glare and light hypersensitivity. But otherwise, the image is very sharp, and you really can look for far and the computer and also read with these multifocals in a very sharp manner. So it is already the case. And these patients usually are older patients, so they have presbyopia. So they're very happy usually if they can see without any type of glasses, because they're very accustomed to having glasses since they have this presbyopia since their 40s.
Thank you so much, ladies and gentlemen. Thank you so much, Vincent, for this masterclass about the eye surgery. Ladies and gentlemen, please give it up for Vincent Quinn.
Thank you.
What it meant to be will eventually be a memory of a time.